This speaker is Jeff Allport, and he is the Vice President and CIO at Valley Presbyterian Hospital up in the San Fernando Valley. And, you know, I think a community hospital like Valley Presbyterian has some pretty interesting challenges, and Jeff's going to lay out some of the things that he's been trying to address, maybe compare and contrast those to some of the challenges that other organizations has. Jeff has been at his current role since September of 2013. Before that, he was both an independent consultant, and he also worked at St. Joe's, also Perot, and has been in the healthcare IT space for a long period of time. I've always called him one of the smart CIOs. So I always learn something when I hear Jeff talk. So without further ado, I would like to turn the podium over to Jeff and have him give you his perspectives on technology, partnership, and care. Thanks, Jeff.
Well, I want to thank the program team for inviting me. This is actually one of the best events in Southern California. Steve, I think, said he's organized all of them, and I think I've been to all of them. I'm just going to offer you a little bit of a story and let you kind of think about the things that we've learned at Valley Presbyterian. So first, a little bit about us. Now, we're in Southern California, so most of you know where the San Fernando Valley is, but when I've gone to other locations and given a talk, I always have to tell everybody it's behind the Hollywood sign. So the thing to know about our hospital, it's 350 beds. We have, 5,300 plus discharges. A couple of important points. In San Fernando Valley, the largest inpatient program for pediatrics, and actually for several years in a row, the leading delivery mechanism for children coming into this world. So we are significantly positioned in the community for OB services and child services. We do have a fairly busy ER. I think it's the second or third busiest ER in the LA area. And about 13% of those patients get converted into inpatients. But it's an extremely busy place, and that leads to exciting nights all the time. We are also a safety net services hospital, so we're recipients of disproportionate share and other kinds of incentives, and we have a large mix of Medicare and Medicaid under the Medi-Cal program of patients. Our medical staff's about 600 docs. We have about 1,600 employees and a number of certifications for STEMI and stroke. Our mission is to improve the quality of health in the San Fernando Valley. Pretty simple, pretty straightforward, but it is a community hospital, and our vision is to just be excellent in doing that. So part of the talk I wanted to give today is just to talk a little bit about all of the excitement that we get in this industry, and you heard a lot about it just a few minutes ago in the previous speakers, but how do you wrestle with making that practical and actual in what is really a much smaller kind of setting? And a community hospital provides a different way of experiencing that than a large health system, and as Steve said, I've been part of both. So part of the story is to talk about that. So the first thing, and I think all of us know this in the CIO world, is you're always looking for that recognition from the executive team. So what do you get in a small community hospital? One of the things you get is you're part of the C-suite. So in a way, technology value is understood in almost every executive discussion about the hospital. And I keep falling back on previous times in larger health systems, thinking about where the next place of approval needs to occur up the chain, and I keep realizing that there isn't any other place. The board is the last place, and part of the value of being on the executive team is that you really get to know your board members well. So opportunities for operational and strategic influence, the board meetings, the board retreats. So one of the results of that is that we get kind of some built-in strategic alignment for IT and some built-in governance, because if the executive team isn't agreed upon an initiative that uses technology, then actually you don't have a governance problem anywhere else in the organization. So it's a nice feature of a community hospital, and I have enjoyed that quite a bit. You also get a lot of access to your stakeholders and your clinical users. I think it was really good to hear from Clark as he talked about Mercy Hospital, because when you're in a health system, again, you're kind of living in a corporate environment, but understanding what's happening at the bedside among your patients receiving care is, I think, really exciting and very helpful. So, you know, our users and stakeholders are just down another corridor. We can get all of our clinical and operational directors to serve as stakeholders. We do rounding, so we can round the hospital. It takes about an hour to get from every unit, through every unit in the hospital, maybe an hour and a half, and to talk to specific users, nurse managers, and so on. You know, it's a place where IT can get its nose in everybody's business. And how often in healthcare IT are we talking about providing technology that enables clinical value? Well, you have sort of a ready-made opportunity in even just the simple exercise of rounding. We have a very, I think, forgiving environment. So the clinical staff and the IT staff feel very much like we're all in this together. And very good opportunities for physician relationships. We have a community that is fiercely committed to this hospital. I'm always surprised because it's LA after all. We've got, you look one direction and you can see Kaiser hospitals, you look another direction, you see Providence hospitals, you look another direction and you see Dignity. And yet here we are, very strong, standalone, with a community that's very, very supportive. And part of it is understanding that community. So I mentioned that we have a large publicly funded base because about 70% between Medicare and Medi-Cal. So when I'm often called, like many of you are, by vendors that want to discuss the value of some products, I get the question, are you part of an ACO? And my answer is, well, which answer do you want? The official one or the real one? The official one is no, we didn't sign up for any CMS program to be an ACO. We're not participating officially as an ACO. But I've got 128,000 Medi-Cal lives capitated to us and to the local federally qualified health centers. And together, we're being paid, capitation fees on a, per member per month basis. And our objective is to deliver care in a continuous fashion between the clinics and the hospital to these patients at the lowest possible cost. And so when I recite that story, I ask the other person, so do I have are we in an ACO or not? And I think the answer is yeah, we actually are. The other thing we get, I think I just went backwards, sorry. The other thing we get is the opportunity to create some governance structures, and I wanted to just tell you what we had in place because that really helps us carry out our vision in IT. So obviously we have the board and the executive team. The medical executive committee has a lot to say about IT, and our quality committee does. And it's taken some time to get the quality committee to recognize that actually IT is just as significant a component as any other patient care, but now we're at that stage, and it's pretty exciting because it changes the discussion that happens in a typical quality committee meeting. We developed a medical informatics committee. This did not exist before I got there. It has typical physician advisory council functions. We go over technology opportunities. It's very well attended by our physicians. Meets monthly, used to meet weekly, and this is our area for hammering out clinical discussion around order sets, our physician documentation capabilities. We have a physician champion that chairs that, and he is essentially our CMIO. We also have another committee called the Clinical Transformation Steering Committee. This committee has evolved over the years. It started out as a implementation oversight committee for when we were doing CPOE and such, and it's now become sort of the place to bring a decision document. It's just a format that we have that says, should we or shouldn't we add certain kinds of content to our EMR? Should we have our screens oriented a certain way? What about order sets? What about forms? So it essentially functions in a way like a typical forms committee would, but it's really about the electronic capabilities of our EMR. So we had two major initiatives. The first one that we've been executing over the last few years is Clinical Process Redesign Plus. And the only reason we call it the Plus is because several years ago when they first put in an EMR at Valley Presbyterian, the project was called Clinical Process Redesign. And when I got there, I said, well, you know, we've got a lot more we've got to do, so let's just take the same brand and put the Plus on there. One of the problems with a acronym like CPR Plus is I was at a medical committee meeting when we were talking about training for our physicians to learn how to use the EMR and do CPOE, and one of the physicians says, I already have my CPR certification. You know, you live and learn on acronyms. So what we did is, you know, obviously we had to address the meaningful use in a way that's sort of old news now for a lot of us. The EMR expansion, you know, CPOE. It's interesting now, one point I wanted to make on the CPOE is in our community hospital environment, we didn't have so much a problem of standardization as really adoption. I know in a larger health system, part of what happens under a CPOE is you're working, you know, vigorously on standardizing things like order sets and so on. We felt adoption was actually more important than standardization, and actually it really worked well for us because the physicians fell into standardization a little bit more kind of passively because they just found the easier way to do things was actually to use the order sets and so on that had been created, again, with a lot of clinical input. The other thing, you know, we've done, you know, scanning and archiving, and we're very successful now with Dragon speech recognition. But even though this does not, there are hospitals represented here today, in fact, one that will be speaking next, where HIMSS Analytics 7, you know, is an achievement. For Valley Presbyterian, a year ago, a little over a year ago, we were at a 3.4. And in 1 year, because of the clinical transformation work headed by this committee, we got ourselves essentially up to 6. There's one little thing I have to do in order to achieve HIMSS Analytics level 6. But for us, in a hospital like that, it was really an exciting adventure to get this much stuff done in essentially a year and a half. The second thing, as a major initiative we had was to build a clinically reliable infrastructure, and that one we went by CRI. I'm going to talk about one of the stories about that, but VDI, or virtual desktop, became a key component of what we delivered. Disaster recovery was a major part, and so was revamping our network. Before I go into those stories, though, I want to just talk to you about sort of the philosophy that we've brought to IT in Valley Presbyterian, and then tell you the few stories. So we built a information technology strategy framework out of 16 maxims, I guess, and we set aside the mission for IT to be to provide and support the information technology tools necessary to enable Valley Presbyterian to do its own mission. But what we did is we mapped out 3 significant IT pillars. Can we provide a secure and reliable architecture? Can we govern it in alignment with our organizational goals? And can we deliver it as a service? And so just a couple examples of how these worked out. So one of them on the left is we will strive for maximum system redundancy and elimination of all single points of failure. We're not saying we've done all that. What we've said is that's a key component of our IT strategy. The bottom pillars are simply which hospital goals does that particular maxim point to? And so we did all the mapping to all of the hospital goals. The second one here, just as an example, applications will be deployed by virtual client technology. And we'll try to be as endpoint agnostic as possible. So once again, that just was one of the governing maxims. As we go into other areas, so they're kind of color-coded here, an example of governance is we'll always give highest priority to fulfilling the mission-critical functions of the hospital. And in terms of communicating as a service, we agreed that IT service delivery will be measured with reportable metrics and drive towards continuous performance improvement. So the point of all of this is to say that even in a community hospital, you have to start with a framework that says, what's our sort of undeviating standpoint to start on a really engaged and participatory set of activities. So here's my stories. I want to talk a little bit about our challenges around summary of care, which is a meaningful use initiative, a little bit about VDI, and a little bit about disaster recovery. So I think most of us in this room are familiar with what a summary of care is. It's, we call it a CCD often, but it's essentially these elements that are supposed to facilitate health information exchange among providers. As you know, one of the measures for meaningful use was for all providers to be able to provide this electronic summary care at the transition in care for at least 10% of our providers. Again, that's relatively reasonable, but something new and something attached to meaningful use. So in our environment, we had to look at, well, what can we leverage to meet that goal? That was actually our hardest meaningful use challenge. And I've been doing health information exchange kind of work for years. And this turned out to be one of the hardest things. And why? Well, let's talk about the challenges side. We have multiple small primary care practices. There's not a single multi-specialty practice I could go to and say, you know what, if we just exchange information, we will hit that 10% without a problem. There's nobody there for us in that capacity. We have multiple small post-acute facilities. So it's not a single threaded mechanism in terms of our post-acute referral network. We don't have an official one that we can rely on. The health plans sometimes govern those, but really every patient has up to potentially 3 possible follow-up care facilities they can go to. And we don't have an owned or contracted large medical group. Now, what we do have on our side is We have known transfer patterns, so we know where our patients go. We have relationships in our community, and we can trade on the loyalty that our community has. And we have this ACO thing I was talking about, which is our federally qualified health centers as partners. So our challenge was, how do we do this transfer to post-acute? You know, typically a post-acute facility is not meaningful use aware. They're not in the same boat that hospitals and individual physician practices are. Their EMR environment is very different. They're heavily dependent on fax communications and typically pre-discharge communications back and forth, because you're trying to figure out where you're going to place the patient. In order to do that, you got to figure out if there's room at the SNF, and the only way to do that is to send them data about the patient, and so on and so forth. Primary care follow-up, we found that a lot of our smaller docs just weren't that meaningful use aware. Again, very different from an integrated delivery network where, you know, the CIO of the practice side is working very closely with the CIO of the acute side, and together working to achieve those goals around meaningful use. We had a lot of docs that just didn't really understand that, some not even electronic. And then internal understanding within the hospital, there were a lot of process issues. Who really owns the discharge process? You know, I think you can ask 5 different people and you'll get 5 different answers sometimes, because it could be case management perspective, it could be a quality perspective, it could be the doctor's perspective, it could be the nursing perspective. So we had to deal with all of this just to figure out how we're going to transfer a summary of care. So what we did is we found a couple of strategies to be very useful. The first was in sending those direct messages to the post-acute providers, we just made sure we had a webmail portal, a secure webmail portal that allowed them to come in and do that. And that removed any technical barriers for the recipient, because if they didn't have an EMR, we weren't going to go down this road and say, well, let's figure out how we can get you a directed message. We gave them one of our direct addresses. We gave them access to a webmail portal where they could pick up that direct message. And for the first time, a lot of skilled nursing facilities, a lot of long-term care, and even board and care facilities started to say, oh, this is kind of cool. This is actually better than a fax machine. And it just took some time to do that, but that was hard-earned work because it was face-to-face visits with multiple post-acute facilities. I think my favorite was educating the physician offices about their own EMR. I actually have a member of our team, IT team, who would look at the website. We'd figure out what the EMR was that a physician practice had. He'd look at the documentation for that EMR, either available through a website or by contacting someone, determine what buttons and features and configurations need to occur, and then we would go to the office and tell them what they needed to do with their own EMR. And that would gain you potentially one doctor to connect to from the standpoint of direct addresses. So we had to do that over and over and over again. And it was, again, just a lot of hard work. We had to educate our case management nursing staff because they had to figure out how to do something new, which was track their discharges when, if you do the right thing in our EMR, that would generate the transmission of the continuity care document. So and then finally, we wanted to really understand what would happen coming in if we were receiving a patient. What could we leverage just to help somebody else achieve their goals of sending a continuity care document to us? And we were able to rely on a couple of really good partners. Another hospital in the area has a very specific referral pattern. If they have a pediatric emergency case, they will send that pediatric case to our inpatient pediatric department. So we partnered with them and said, look, every time you're doing that, make sure that continuity care document comes in, and then we'll get our pediatrics department to start checking for those to see if we can at least start to get close to the holy grail of information exchange on a very specific case like that. So the web portal looks like this. It's basically an inbox, but it's targeted for you, the user. Therefore, security issues are relatively clean because you don't have someone, sort of navigating through a web portal looking for just anybody. And our best successes were with our federally qualified health centers, again, in the San Fernando Valley, two in particular. They used, we have a Meditech EMR. They used NextGen as their ambulatory EMR, and we've got the proof and showed the wonderful examples, and the physicians were thrilled that they could get information from a hospital, let alone a community hospital, that maybe had to work really hard to develop the opportunity. Our post-acute facilities were getting it, and they have actually done pretty well. Rehab facilities as well, and now we're starting to get a little further with them, again, on health information exchange. So that's just sort of the first example. Again, the high points of that are simply that we had to do a lot of work where in developing relationships, not technology, relationships to just make it possible to get that threshold achieved. The second story is about virtual desktop. And the single most important issue we wanted to resolve was it takes too long to log on. I think this is a normal experience for most people in technology in the room. We had the card reader, but there was still, authenticate and wait. So we really partnered with a number of people, but the most important thing was we developed a single sign-on VDI design, and we are using VDI, not Citrix, in our environment. And we did the integration with Meditech for their single sign-on capability, which they call MSO. And the partnership turned out to be really effective. And so it was built off of an analysis that we had done of our environment. So again, smaller environment. We have approximately 1,200 endpoints, workstations in use. And if you take the 80-20 rule, it's about 100% accurate. 80% of those devices are used by clinical users. And the other 20 are what we would call an information worker or power users. And if you could take that 80% and in one fell swoop give a common desktop that roams with them from device to device, you kind of gain a lot immediately in terms of endpoint management. And of course, this was a year ago, so a year and a half ago, so we were struggling with Windows XP to 7 conversion issues, and there you have it, 80% gets converted in one fell swoop. What it did is it required us to change our paradigm a little bit. And I like this term, demote the PC. We wanted to demote the thing that was your computer and turn it into an appliance. And so we call it a clinical computing appliance. And we only provide in that desktop the stuff you need to do your clinical work, period. So you get Meditech, you get access to PACS, you get a few other things, including email and browser. We eliminated all the use of Microsoft Office for 80% of our workforce. It's not that they can't use Office, but they would never do it on a clinical workstation. They would go to a different workstation to do that. And actually, we were able to renegotiate all of our work with Microsoft to flip back to device CALs rather than user CALs and achieve some significant savings. The other thing we can do is we could leverage an environment like this. We have a pop-up thing that comes up. That's the little image on the lower right. So if we need to tell docs that there's another Dragon class scheduled or some things like that, it just pops up on their login. And they'll see it on any device. We did have a few challenges. So, for example, Meditech has some forms that they use where they rely on Microsoft Word or word viewing capability. And we actually had to dumb that down to a little bit more pure text just to get away from having to have Microsoft Word as a resource hog on the virtual desktop. So it was just a way to do this, and what we did is we created this ability to move from workstation to workstation, tap in with your proximity card, and just begin your work. Now, what were our outcomes? So our outcomes were that we had a steady measured reduction in password reset tickets. Now, I still believe we have way more than we should have, but we have a lot less than we did. And that's because effectively you just have a user knowing that their workstation is following them around as they go from place to place. We have a standardized user experience, only one desktop to manage, and so on. But we learned some lessons in this one, and the lessons I think are really important because as we talk and get excited about technology, such as again in the last speaker, getting things to actually work in the real world turns you into a pragmatist. You know, you can go from idealist to pragmatist very, very quickly. And there are a lot of things that you can do wrong. And so learning, relearning, plan, do, check, act, the whole continuous improvement process is really essential. So one of our lessons is we learned we could do a little bit better with our workstations on wheels, with our WOWs, especially with battery management on the ones that couldn't be anywhere near an outlet. We understood that, or learned that single sign-on is sometimes unintuitive. From a behavioral standpoint, we saw the nurses moving their WOWs around and keeping their computer with them, even though there was a perfectly good WOW somewhere else down the corridor or near the patient room. And I used to ask, well, why are you doing that? And sometimes the answer was, well, I found a good working one, okay? And so, and sometimes that was true because I can't say that all the time our workstation infrastructure was completely solid. But then I would say, well, you can just tap your proximity card over there and pick up the same session of the EMR that you're working in now. And for a long time, that concept didn't sink in. And the reason it didn't sink in is because they were still wedded to the workstation. And if you start asking, so I think Clark earlier said, go ask questions, go really understand what people are trying to do. So if we ask the next round of questions, then you start learning and understanding that medication distribution for a 1-to-4 ratio for nurse to patient, where the patients are in a bunch of different rooms, but all the medications are in a drawer next to your cart, you suddenly realize it doesn't matter whether you can tap your card and execute single sign-on. You aren't being effective if you can't move that sort of portable pharmacy around with you at the same time that you're working on the EMR. So as we looked at all those issues, we realized that even plugging the workstations into the rooms required another method of medication distribution, because now you don't have a drawer of meds moving around from room to room. You have to do things where you either distribute them from the room or do a different form of a centralized distribution. So again, the partnership between the clinical side and the technical side, I think, is kind of exemplified in that story because everybody had to learn something. And the first round of questions wasn't enough. It was really the second round of questions that addressed what the real workflow concerns were and a way to optimize. Anyway, that's kind of the story about our VDI environment. It's a constantly evolving story as we get better and better at delivering it and making it stable, more stable, faster, and as we finish this exercise of getting everything into the individual rooms. Now, the third piece of a community hospital, and again, maybe the fire drill reminds us of this, you know, you've got to have some ability to recover from a disaster of some kind. So we found a partner and engaged using some replication technology through EMC, and we have a continuous replication capability now. It's going all the way over to San Antonio, Texas at the moment, where the other data center is. And you know, you can't just say I've got a DR strategy. You've got to say I've got a proven DR strategy. So we actually did a test a few months ago, actually in September, and our goal was to achieve about a 2-hour return to operations and a 2-hour window of our recovery point back to the place in the EMR. And in that test, we got there in about 3 hours. And we had physicians and analysts and others getting on Meditech, running it from a location in San Antonio, and successfully doing all the normal things that we do. We found a few issues, like you would in any kind of test like that, but remember our mission. The mission of Valley Presbyterian is to service that community, and should something happen in that community, you got to be able to get to your medical record, and we demonstrated that you can. And I'm sure many of you in the room remember that's a community that was hit very hard by an earthquake within the last 30 years. So, but it starts to raise some interesting questions. When you ask questions about what am I going to put in my recovery site, you say, well, I think your EMR should be there, and you go, yeah, that's a great. Then you say, what about my integration engine? Because nothing runs without that. And then you start to say, what about my pharmacy system? And then you start to ask, what about all the add-ons to the EMR that enable billing and coding and all sorts of other things? And it starts to look like a jar where you're dropping marbles in the jar. And as you keep dropping them in, you're saying, more and more of this stuff has to get backed up and built for recovery off-site. Well, if you do that long enough, you might as well use a different term from disaster recovery and start talking about co-location. Because what you're essentially doing is saying, I'm building up a data center someplace else. And what does that mean? And I think, again, it was said earlier that it's a little bit of a buzzword to talk about cloud, but the reality is that starts to take you down a cloud strategy. So I've always said, gee, what happens if we go into one of those disaster recovery tests I just told you we were successful in, and we never flipped the switch back? What would happen? We would be running in a remote hosted solution with complete recovery capabilities built in. And now, that's a little idealized way to state the problem, but on the other hand, it's exactly along the lines that Clark was mentioning earlier today about getting out of the data center business and focusing on high-value analytics and business and clinical process. So our current projects to enable us to be there is to make sure we have a solid network that can support that. Because it doesn't matter how much you co-locate someplace else, if you can't get to it, that's a little bit of a problem. So we've been building high-speed fiber links outbound with multiple paths on our campus, in and out, with several partners, and optimizing that. And our reason we're doing it is not just to be able to enable that cloud capability, but when you get the kind of gains we've gotten from clinical adoption of our software, the last thing you want to do is pull the rug out from under anybody with an infrastructure issue. And, we have had a few of those. I mean, a lot of hospitals have those, and they're never comfortable. They're never comfortable for a CIO, but they're just not comfortable for anybody to have to think about the electronic tools and why they're not working. So that's our mission, that's our goal. And so the things that we're looking at next really sort of feed off of those accomplishments I've just talked about. So obviously there's always more to do with meaningful use in our electronic medical record. And as I mentioned, we are now really working through the details of how do you migrate more and more of your infrastructure to the cloud. We do recognize, and I think I laid out the landscape a little bit earlier, with our ambulatory environment, we do recognize there are some things we need to do. It's not the same as an integrated delivery network, but we do need to expand and branch out in our ambulatory partnerships. And again, those great places to start are those FQHCs that share the same capitated patient population. Analytics and data, which we all talk about, everybody talks about big data and so on, but I mean, that's really the next step for us. And then plugging into the innovation landscape, which you heard a lot about. I think it's really fascinating, and I know there's a lot of literature on this already, and many of you have read this, studied this, and talked about this, but that meaningful use stage 3 requirement that for the patient portal, that you can satisfy that by providing an API to your EMR to something else, sort of raises a lot of interesting questions. I think there's certainly some prominent names that have questioned the validity of that requirement. But if we are moving to mobile health, as we heard about earlier, then that API, being ready for that, is sort of a high priority. And the problem in our environment as a community hospital is we can't necessarily know what strategically at this point what that's going to look like. So our strategy has to be sort of be ready to kind of pivot and adapt anywhere that innovation landscape goes. We're not going to be at the forefront of that innovation landscape, but we want to be able to harness it and get some value out of that immediately for the patients who need it. So that's really my presentation. I wanted to just, give you a little bit of a perspective from the other side.